This is Daniel Tobes. I'm presenting No Oral Opening, No Problem with Brian Thoma, Dr. Imelda De Vera, and Dr. Jack Fulby. So our patient presentation begins with a 13-year-old female with a history of rhabdomyosarcoma and secondary osteosarcoma of the mandible, who presented to our institution for an open tracheostomy and gastrostomy tube placement in preparation for her tumor resection and facial reconstruction surgery. Due to the size and location of her tumor, an awake nasal fiber optic intubation was indicated. After multiple attempts were performed by multiple different providers, eventually intubation was successful. This presentation will focus on the management of fiber optic intubations in children, especially awake fiber optic intubations. So the first thing to note when talking about fiber optic intubations, especially awake fiber optic intubations in children, is the many differences between said intubations in children versus adults. Namely, there are several anatomic differences. So as we can see in this picture, the pediatric airway has its narrowest portion below the vocal cords, which means that just because you are able to get your tube through the vocal cords does not necessarily mean that it will pass all the way through to the mid portion of the trachea where you would like it to sit. Also, children tend to have trachea that are more anterior than their adult counterparts. In general, kids have smaller airways, which means that when performing a fiber optic intubation, you're more likely to contact the mucosa, which can obviously make fiber optic intubation much more challenging. Kids have a higher oxygen consumption, which in our sense means that you have a lower safety margin, so you have less time to finagle the tube in before they start to desaturate. And generally, children are going to be less cooperative than their adult counterparts. So you may need more sedation, or you may need to caress them with a little bit of verbal anesthesia. Our proposed method, specifically for awake nasal fiber optic intubations. So the first step is always to obtain an IV prior to your intubation attempt. This can obviously be challenging in children, but is of the utmost importance, both for safety and sedation reasons. You need to determine which nair you are going to use for your intubation, so determine which one has better airflow. And then you want to pre-medicate, usually both nairs, with oxymetazoline spray, which is over-the-counter Afrin. Before entering the operating room, we typically give glycopyrrolate as an antisialagogue up to 0.01 milligrams per kilo. And then when you get in the room, you want to make sure that your patient is appropriately positioned, of course. You want to thoroughly topicalize the airway. So this typically starts in the preoperative area with breathing treatment with nebulized lidocaine, nebulized 4% lidocaine. You want to, if the patient is cooperative enough, give them some 4% lidocaine cream that they can put onto the back portion of their tongue and then kind of rub around in the back of their oral pharynx to help anesthetize the mucosa there. And then for the actual intubation itself, you want to prepare 4% lidocaine syringes to use through the fiber optic scope. Overall, you want to make sure that your dose of lidocaine does not exceed the toxic 4.5 to 5 milligrams per kilo. And then you want to prepare your ET tube. So we use the Blue Portex Polar preformed endotracheal tube. You want to load this tube onto a pre-lubricated fiber optic scope, and then we usually tape at the top of the tube to the scope. And then you want to adequately lubricate the outside of the tube. And then through your injection port in the fiber optic scope, place an epidural catheter with an alligator clamp on the proximal end, so that you can inject your 4% lidocaine. Now it's time to sedate the patient. So we typically administer a combination of midazolam, ketamine, and fentanyl. Midazolam up to 0.1 milligrams per kilo through the IV, ketamine up to 1.0 mg per kg through the IV, and fentanyl up to 1 mic per kilo through the IV. Next, you want to serially dilate your nair with a nasopharyngeal airway that has been adequately coated in viscous lidocaine. We usually leave each airway in the nair for 10 to 15 seconds and then exchange up to the next size, ventilating in between the entire time. And now it's time to perform your fiber optic intubation. When you get the tip of your fiber optic scope right outside the cords, you want to make sure that your epidural catheter is just barely poking out the end of the fiber optic scope, and then spray the cords with your 4% lidocaine. Typically helps if you spray above, at, and below the cords. And then once you are able to pass your scope past the cords, you need to Seldinger your tube off, and you can adequately confirm placement, usually after the patient has been put under general anesthesia with an IV induction agent. Thank you.